spirit.
Welcome, and it's our pleasure to welcome Dr. Veronica Sikka, who I first knew as a math student, and Mr. Tharp had her for biology way back when, before we became administrators. Veronica graduated from Governor School in 1999, so she's one of our TJ alumni. She played tennis as a Viking, and was in debate and model, or not model, it was We the People. We the People. Right. So that's kind of the Governor's School side of Veronica, and now she has her PhD and MD, and is waiting to know whether she's going to be an attending at either MCB, attending physician, or at Jamaica. So we welcome her and are excited to have her back.
Appreciate it. Thank you. Thank you all so much for having me. Like Mrs. Taylor said, my name is Veronica Sikka. I was from the class of 1999. I'm currently one of the chief residents at the Department of Emergency Medicine at VCU. I thought I'd give you just a little bit of background about me. Just click next.
I do the arrow.
Oh, there we go. Uh-oh, a little too far. So just a little bit about me. I was born and raised in Virginia, never left here, and I don't think I'm going to be leaving here anytime soon. I was in Petersburg until high school. Realized that it wasn't as challenging. I needed something else to kind of take it to the next level. Governor School was gracious enough to accept me in 95. I was just thinking yesterday, I was talking to my mom, I was like, did I go to Governor School in 94, 95? 95 to 99 was when I was in the Governor School. These were just some pictures I was looking through my old photo albums. I think our pig lab or one of our biology classes with Mr. Tharp, of all people. And this is when I graduated, chubby. This is our 10-year class reunion we had 2 years ago now with some of our classmates. And this is Taylor, a lot of our faculty attend the 10-year class reunion. I'm still in touch with a lot of my classmates on Facebook. That's what we were talking about just a few minutes ago. After Governor School, I went to the Guaranteed Med program at VCU, where I did my BS in biology. I graduated in 2 years because of all the awesome AP and college credit that I got here at the Governor School. So I went into undergrad with like 75 credits, and didn't know what else to do with myself, and I figured I was done with undergrad. I did because I was guaranteed med for 2003, I had 2 years left, so I did 2 masters. I did a master's in health administration at VCU, and I did a master's in public health at the University of Massachusetts Amherst. I started medical school. I realized I really liked health policy, health administration, and so I did a PhD in health policy at the Department of Health Administration, and graduated finally in 2009. Today I'm in my emergency medicine residency. It should hopefully finish in 2012. My program director always tells me I'm like a 6-year track. It was supposed to be a 3-year program. And I should be graduating in July. I probably am going to be an attending at VCU, officially signed, but I also do a lot of moonlighting in Chippenham, which is one of the community emergency rooms. And in May I'll be going to ABC News. I'm doing some work with them as a medical correspondent. With Dr. Oz, Nancy Schneiderman, and all those folks up there. So very exciting to go up there. So we'll see if I actually stick around here, but for now, hopefully I'll be at VCU. So I wanted to kind of give you a little bit of an idea of what I do and kind of compare emergency medicine in the United States versus in India, where I'm originally from. You know, I was born and raised here. I used to go to India a lot. The first time I actually went to India was when I was in high school in '94, prior to starting Governor's School. And there I just went to visit family and friends. But I always realized that I wanted to give something back to my country. And there was a lot of gaps in terms of their healthcare, and there's still so much that needs to be done there. So I've just started going back recently and starting to help them in terms of their emergency medicine program. So I kind of want to give you a little bit of an idea of what emergency medicine is like in the U.S. We'll compare it to India, and we'll just kind of do a quick recap of how the 2 countries compare and how India has significant strides to make. Not sure how long it's going to take, but they're still very young in terms of their healthcare, in terms of just being essentially got created in 1947. So we're still trying to figure out what we need to do with ourselves. But in the U.S., emergency medicine is awesome. It's a new specialty. It's essentially one of the younger ones. We're accredited. Once you graduate from your ER residency, you get you can take your board exams, and then you can become a fellow in the American College of Emergency Medicine. medicine. The funding of emergency medicine care in the U.S. is interesting. If you come to the ED, we have to treat you. So essentially, you come in with a stubbed toe. I've been working there. I'm actually going there now. You come in with a stubbed toe, you got to get treated. Insurance or no insurance. You could have not a dime on you, we got to treat you. You come in with a heart attack, we treat you. So unfortunately, with all this reform that we've been having, emergency medicine and the ERs are getting more and more busy. We go on diversion now. I usually start my shift 7 a.m. to 7 p.m. when I'm on days, and 7 p.m. to 7 a.m. at night. Days are really busy, but we started going on diversion around 11, 12 o'clock. We're that busy. We're 30 deep in our waiting room. Every bed is full in our ER. And unfortunately, because of the way the funding is, people don't have access to primary care. They, come in with a stubbed toe, or, my pinky hurts, or I got a little, cut here. It's different in India. If you don't have money there, you don't get treated. It's nationalized healthcare in India. Everybody's supposed to have free, unlimited access. But when you go to this one hospital that I go to, the physicians are very blunt in saying, if you don't have money to treat you, to give me, I don't have money I can't treat you. So they're very blunt. Here, we'll do the whole thing. You need an MRI, we'll get you an MRI. You don't even need to have $1 on you to pay to us, because it's different. We're in Tala, we have to treat you. And it's funny, because sometimes I'll see a patient and the registration clerk will come in and she'll have to take the person's name, get the social security number, get permission to be treated. And she's like, the copay is $30, and the patient inevitably all the time will say, I don't got no $30. And then they'll be like, well, we'll take anything, $1, $2, $3, and I'm like, since when did we start begging for money here? They don't got any money, as every other patient. So, but we have to treat. We have to make sure that we do whatever we need to make sure a patient gets the best care possible, because then there's also the other end of the spectrum, which is malpractice, and everybody's always looking to sue you if they're not satisfied with their care or something goes astray. So it's different in the U.S. Our scope of practice is huge. Everyone always says emergency medicine, we're the jack of all trades, but we don't master anything. We run our own trauma bay. Any gunshot wound stabbings, we take care of. We put in chest tubes, anesthesia, we intubate patients all the time. Intubate essentially means we put them to sleep by putting a tube down their throat. A lot of times when they can't breathe, we're the first ones to intubate. We always have our anesthesia colleagues as backup. We do orthopedics. We splint patients. Patients come in with fractures. We have orthopedics there as backup, but at the same time, we do all of our own splinting. We do OBGYN. A lot of times people come in with vaginal bleeding. They're new onset, early pregnancy. We make sure that the baby is still fine. We do ultrasounds of their belly, make sure we can still see the heart beating. And then we usually get them to follow up with OBGYN. Cardiology, patient comes with an MI, a heart attack. We're the first ones to handle that. We do neurology, a lot of stroke patients come in, seizures, patients that are in status epilepticus. That's our scope of practice. Radiology, a lot of times, we were just talking Judson Fries, one of my classmates at MCD, class of 99. And sometimes at night, when they're slammed to traumas and they're trying to read all those films, we need to be able to read our own plain films and our own MRIs and our own CTs. So, like I said, we can do a little bit of everything. We kind of stabilize the patients, but then when it's for more complex care, for actual casting, we'll send them to orthopedics, or a patient has an MI and they need to get a cath, they're going to go to cardiology. But we kind of are the front door to the entire hospital. Now there are a lot of people in emergency medicine who are residency trained, like me, who actually have the full emergency medicine focused training. But then there's some people that are grandfathered in, who were originally trained in internal medicine or family practice, who then somehow kind of learned the tricks of the trade and then are now ER doctors. And the job market is awesome. I've been looking for jobs lately, and we do something like 9 to 10 shifts a month, and the salary can range anywhere from $350 to $400. So very nice lifestyle. It's extremely competitive. This year, the match process, we didn't have one unfilled space or spot in the entire country because of the lifestyle of emergency medicine. Essentially, everybody goes for lifestyle. Dermatology is very competitive, 9 to 5. You got a mole, I'm not going to come in to see you, come tomorrow to my office. So people go for lifestyle, and emergency medicine, I think people are starting to pick up on. Okay. So emergency medicine in India is just an entirely different field. It's unrecognized. There's no such formal training for emergency medicine. people normally will do internal medicine or family practice and then kind of grandfather in, kind of learn the tricks of the trade for EN. The layout there is bizarre. I have some pictures to show you of a hospital. People are all over the place. Patients, their families, sometimes the family's sitting on the bed and the patient's on the floor. It's just crazy. Emergency medicine, I mean, you think it's crazy in the US. I go to India just to get a better appreciation for what I do here. Because sometimes I'm like, you know, we're 30 deep in the waiting room and this place is a zoo, but then I go to India, I'm like, we got nothing on India. We're totally fine. The funding of ED care we briefly talked about. Essentially, you don't got money, you don't get treated. And it's really, we were on rounds one time, and one of the attendings there essentially like put his hands up and said, you know, you don't have money to pay me, I can't treat you. I'm sorry, it's just like that. And you look at the patients' faces, they're so helpless because there is a lot of poverty unfortunately in India, and we're still trying to get over that. But in a lot of times, you know, when they draw blood, the patient will have to take the blood to the blood bank with the rupees in their hand to pay for that blood to get read. Then they bring the report back to the doctor, and the doctor obviously, I mean, it's just so different here. You know, you draw blood, the nurse sends it to the lab. There's no, like, even a mention of money, or patient's family don't have to be involved. It's just entirely different animal in India. There's a lot of work that needs to be done. I made 2 trips back, 2009 and 2011. We did 2 in 2011, 1 in 2009. My brother is attending at MCD. He's already done residency. So we usually go back together, and then we're going to go back in August to kind of continue our work. INDUS is a organization and a conference that they hold every year between the US and India, where the emergency medicine physicians from the US go to India to kind of treat them to teach the basic skills like intubation and how to use splint. And I mean, those things are just skills that they don't have, but it's their basic fundamental core principles to emergency medicine. So we're trying to help from the US side. A lot of doctors go from all across the country to train these doctors in India, but again, sometimes it's just like you're talking like this. We're not, you know, talking, essentially seeing eye to eye. So a lot of work yet to be done. I thought the best way to tell you a little bit about India and our work there, we go to PGI. So this is Postgraduate Institute. It's a hospital in the northern part of India, Chandigarh, Punjab, if any of you know where that is. And that's where I'm originally from. So this is kind of like the Harvard of India, if you will. And still, like I said, we've got a lot of work to do. This is kind of like the entrance to ED. So we have waiting rooms in the US. This is their waiting room. So you sit under a tree, you kind of are walking in, you get a little ticket to say you're here, and they'll call you when they get a chance. And I don't even know if they ever follow that system, but it's some formality, and people are sitting out here waiting to eventually get seen in the ED. This is the ambulance there. If you see our ambulances here, they're nice and spacious. I don't know what, and there's like a wooden cot that they go around picking up patients. And I never saw a patient even come in on an ambulance. Usually most of them come by foot, or, you know, families are bringing them in, they're all bloody. This ambulance is there outside of the hospital every day, 24/7 when I was there. So I wonder if you even like had any gas or anything to go anywhere. And the guy you see in the front, I don't know if you can see the driver's like sleeping. So in India, in this hospital, they have 2 halls. So in the emergency department here, we have green, yellow, the peds ED, and then we have our observation unit. Green is where we see our psych and medical patients, and then we have yellow, which is our trauma bay and medical patients, and then we have our observation unit. Here they have Hall A and Hall B. So some patients in Hall A, some patients in Hall B. You can already get a little peek of what's going on in here. I mean, everybody, the brother, family, everyone is in here. They're all on top of each other. Here's the actual hallway. So you see these security guards. You know, I hate to make light of it, but it's just unfortunate. You know, they just don't, they realize that this is a major problem, and you really try to go there and make a difference. I think it's going to take multiple visits, and it's just kind of like you're slowly chipping away at a big problem. But it's just sometimes you see these security guards here, they're just chatting it up, people are running all around. This is the hallway, and you're going into the emergency department. This is a typical medical record there. You can see they write everything out. Here we've gone to completely electronic medical records. My cousin has actually worked in the Obama administration, and he's made sure that every hospital in America at least does something electronic. And so we're still, I mean, he's going to go with me the next time when we go to India to see if we can get any kind of like electronic system in place, because these little pieces of paper, you know, The patients take them home, the hospitals don't keep them, whereas here, we keep our own electronic medical records. I don't give it to the patient on a disc to then bring back. There has to be some kind of system that you keep in hospital. The patients take these home. This is kind of their handwritten electronic records. This is their ICU book. So this is a family member. The kind of families are awesome. There's no here in the US, there's like a pass system. When a family member goes out, another one comes in, there's a limit. Everybody, the whole village can come. And this guy is a doctor. They serve food in the ED, so this guy's getting ready. It's noon time, canteen time. He's setting up to eat. And my brother and I were just absolutely shocked when we were here. Really? These are all pictures that both of us took when we were. This is our first visit. This is the nurses' station. You can see kind of the electronic records just all over the place here on the table. This is actually one of the residents who would intubate. So when you intubate, you take a blade and you look in, you see vocal cords, you pass it to you. And the point is, when you intubate, you have to lift up, so you're not lifting back so it gets on the front teeth and they knock. Essentially, you're always at danger for knocking out these front two teeth. We would always, my brother and I would call him tooth knocker, because he would always you'd take the blade back, and he'd always, when he would intubate, these two teeth would inevitably come out. So, as you can tell, they need a lot of help when it comes to intubating. You can already see he's cranking his blade back. And just little funny things. I was going through this presentation with my mom yesterday. You see the guy on the cot next to him looking at him, just like utter fear. I hope I'm not the next person that's going to get intubated. The guy here, I know, right? This guy over here could absolutely care less. He's texting away. So, this guy would intubate everybody that came in. No, he doesn't even have a pulse ox on. You don't even know when he's satting. Can be satting 100%. You can just wait for him to BiPAP, CPAP. No, patient doesn't look like he's breathing. We're going to intubate. And so then, once you intubate, you've got a tube, and then you have to put an ambu bag in until you get respiratory therapy, which I never saw them come down over there, but we have respiratory therapy. You essentially put them on a vent. You essentially squeeze the bag. So there are not enough doctors and nurses there to do that for you. So this is the patient's family who asked them to take a picture of him. And he's supposed to sit there and squeeze the bag, and he would forget. And so getting any oxygen, so I'm low. Every 6 seconds you got to press this bag. So but the point is, you don't give this kind of management to the patient's family. We take over that. And here, we would never even have the patient's family around the patient after we intubate. We usually have them out in the waiting room because there's already utter chaos. We can't have patients. The patient family here is integral to the care of the patient. They have to squeeze that bag. They remember. This is another picture of a guy whose father was really sick. He brought him in. Finally, they have these portable pulse oxes, and he's crying. He's in charge of squeezing that ambu bag. And you probably can't see this, but this pulse ox reads 40%. So that means that when this guy intubated him, instead of going in the trachea, he went in his esophagus. So he was blowing air into his stomach, and my brother and I was like, I don't think that tube's in the trachea. I'm like, should we say something? This is our first day there, and so politely we're like, can you just take a look? I don't think that it's actually in the trachea. And I took a look, and it was in the esophagus. So a lot of management, and this guy's and he's crying. So as he's hyperventilating, he's blowing. So the guy's belly was not this big. This is all air because it's in the trachea or in the esophagus. And then this guy here also doing the same thing, has a mask on and trying to resuscitate his loved one. The same guy. They also run codes there, but there's no very formal management of codes. We all have code cards. We have ACLS cards that we go through, algorithms, which this is American Cardiology Association puts these out. They don't have formal ways of running codes there, so we go there and try to teach them how to do formal ACLS. And this is a doctor that's doing this. I don't even think he does good chest compression. Plus, the guy's belly is so distended because we're blowing air into the belly. And then this is the patient's family who's trying to resuscitate. I think he forgot to use the bag. So here, we have typical EKGs, nice small machines, those leads, little stickers that we put on them to do EKG. In India, it's if you see those little blue things, those are each of the leads. It's ancient. I had no clue when we got our first EKG. What is this? This is how we get EKG. and they have to call a consult to get an EKG. Like, I don't know where she comes from, but it looks like she comes from like the 16th floor down, like 10, 20 minutes later. A patient we're worried about having an MI comes in, and in the EGs here, we get a stat EKG, and our door to balloon time, from the time we see them to the time we get them to the cath lab, has to be 90 minutes. Well, first you got to get an EKG, and it takes them forever to get an EKG. And you can see this guy in blue is the EKG tech, and so he comes down and puts these leads on, and this patient's going to get it eventually. And here in the U.S., we have nice IV poles. Just a little contrast. There, the patient's family kind of pulls up. They are the IV pole. So, like I said, in India, family is very much integral to the care of the patient. They just use the ambu bag, making sure like the patient gets a good IV. This is kind of the bedside table over there. Sometimes when they don't have like real bottles and things, they just empty out a Coke bottle and put stuff in there. It's just an utter mess. This is my brother. We were on rounds, and so these are the formal rounds that you have to go through every patient. This guy right here is actually attending, or one of the Don residency doctors, Dr. Paula, and then my brother, don't take my picture, was on rounds. Just kind of, we have to go through each one of these patients, and he was the one that actually like put up his hands and said, you don't have money, I can't treat you. There's just kind of like a look of helplessness on patients' faces, which is unfortunately the reality in India. Splinting, so like I told you, here we do orthopedics, we do all of our own casting. Patient comes in with a tib fib or a femur fracture, we'll take care of it down in the ED. We do our own reductions. Reductions, if you crack a bone, we realign them, and then we put a splint on it. So this is kind of the archaic, I don't know what kind of contraption this is, but this is supposed to be the way they do ortho there. And usually we put them at weights, while there they use bricks. So very different. This is a pediatric patient there, intubated, and this is a patient that's actually abused by parents. Was brought in. So I actually intubated this kid, and I just got off of my PICU rotation, and I mean the kids here we're just so fortunate. It just puts a lot into perspective. The care we give our kids is just, I think we even give our kids better care than we give our adults. They're so innocent, they're so sweet. And here, they're the ones that are, I mean, she has a bag, I think it's like on the side somewhere, somebody's forgetting to like, squeeze the ambu bag. So I don't even know what the care was for her, what her ultimate outcome was. This is the new trauma center. Hopefully this will be better. This is right next to the ED that I showed you originally. So this is going to be open in a few years. So I think the next time we go, we're going to actually be going into this emergency department. And then we're doing a lot of work. This is a presentation. My brother did one on airway management. We're teaching everybody how to properly intubate, lift up with the glide scope, not back, so you knock out their teeth. We do a lot of talks on EMS system, kind of how we run our ambulances here versus over there. And then I have done a talk on residency, so I reach out a lot to the residents over there and try to connect with them. My brother does more on the attending level, I do on the level.
Please state your name and office.
Just to wrap it up, just a quick comparison, the US versus India, the EM especially, we're recognized, India really not recognized. Recently it was acknowledged that it's actually something that exists. Here, there are many residency programs across the country, very competitive to get into. Right after dermatology, emergency medicine is ranked in terms of its competitiveness. There's no such thing in India. There's more internal medicine, and you can kind of just work your way into emergency medicine there. Kind of the difference in favor of India is here we're very dependent on diagnostic tests and labs. You come in, you got belly pain, we're going to scan you, we'll get labs, and we'll kind of figure it out later. The labs dictate what we do. In India, they're very astute when it comes to their clinical skills. They definitely have that down. I mean, they taught me some stuff. So I think that's definitely something that we can learn from India. Our ED layout, obviously, we're more organized. We're always improving, but we're always looking to improve. We recognize that there's a fact. In India, you just have to see the pictures to get that. And then the funding. We got EMTALA, which means you come to our ED, we have to by law stabilize you before we can, dispo whether we're going to admit you or send you home. And there, unfortunately, money dictates the quality of care. So with that, just a quick rundown of the differences between the U.S. and India when it comes to emergency medicine. I'll open it up for any questions.
I just have a quick question about what you did your PhD on policy. What was, I guess,
Well, my research was actually on cancer diagnosis in emergency departments and how there's the value. I know in ED we tend to treat a lot of acute patients, acute conditions, MI, a stroke, gunshot wound. But the patients are sitting sometimes in the waiting room, and that's a great time to do a quick, like, do you have blood in your stool? Do you have any lumps in your breast? To kind of be a triage, because we see so many patients in our emergency department. It's a great way to get patients to think about preventive care and what are the rates of cancer diagnosis in the emergency department and the ultimate outcomes of those patients. So I did it in the Department of Health Administration at DCU, so we just published that a few months ago.
Is there any way for us to help you? Like, I know we're not doctors, but is there anything you suggest?
We would love to have you all, if you would like to come to MCD and shadow us. Been in touch with Sharon. We'd love to have you come to. We're having these people from India come to us now, and so we're going to do pig labs for them. Pig labs where we have like pig's feet and help them suture because they don't know how to actually. The patient comes with a huge laceration. It's our scope of practice to suture them back up. So if you all ever want to come and learn first and then teach them, that'll be great because they come in like flocks. Me and my brother just go as two. So I guess they could get in touch with you and my brother and I are MCD, but we've got a huge entourage of attendings. We'd love to have you all come if you'd like to shadow, do some research projects with us. We got a lot of cool projects that we're working on now. Yeah.
Hi, what about the stress level of the ER? My first job when I was 18 was as a unit clerk at acute emergency at Stroke Memorial Hospital in Rochester.
Oh wow!
And I even got, at 18, because they were short-staffed there, I got pulled into the operating room a couple times.
Oh
And
wow!
they're like, Rochelle, you're going to have to do this with no one else.
Yeah.
I know that was illegal. I mean, it was a really stressful job. I don't think I slept my whole freshman year of college. So I'm wondering about your stress level,
Yeah.
because I know that's an intense place, and I also know it's a powerful place.
Yeah.
When all of those components come together and the baby that was brought in an inch from death is suddenly saved and cries, you're crying too.
Yeah, no, you're absolutely right. The adrenaline level is high.
That's when I also decided not to be a doctor.
You didn't.
I'm just wondering about your stress level.
I think emergency medicine isn't for everyone. You've got to, in general, be very laid back. Because I'm one of the chief residents, so I have interviewed all of the medical students who've come through and are interested in emergency medicine. And those applicants were like really high strung. You're like, you ain't gonna do too well in emergency medicine. Like the place is already stressful, you're stressful, it's not gonna be a good combination. So one, I think ER doctors tend to be the most laid back. Patient be having an MI, you kind of stroll in, what do you guys have here? But I mean, if you're freaking out, nurses are freaking out, like it's never a good combination. So being very laid back, I think, is just the general characteristic of a typical ER doctor. And I think that it does get stressful at times, but then it's a lot about teamwork. You have the nurses that are kind of, everybody just jumps in, everybody works together, so it kind of dissipates a bit. But yeah, I'll go home sometimes and I'll go for a run just to get rid of all this adrenaline rush that I have. So very true.
You mentioned a number of times about money. What efforts have HBCU done and are they continuing to do to help offset, like somebody comes in with a minor problem versus a more major problem? Are any efforts doing anything being done to combat that?
That's a great question. We have a program called VCC, which is called Virginia Coordinated Care, and patients that come with a minor, stubbed toe usually don't have insurance. So we have social workers in our waiting room looking through the list. We have our patients ranked from 1 to 5, so 1 is like having a heart attack, 5 is like my pinky hurts. So the patients that are like your 4s and 5s, the social worker will go up to them and be like, so why are you here today? Do you not have a primary care doctor? And 9 times out of 10 they don't. And so then they would give them information that we have a program called VCC where essentially they get free access to a primary care doctor, specialty care. Obviously we have to see them that day, but then in the future it pulls them out of the ED system and hooks them with a primary care doctor. So it's something that we're doing. We have some studies published on how effective that's been. But even our VCC system is getting saturated now. And a lot of times when a patient will come in with a stubbed toe and I'm like, why didn't you go to primary care? VCC paperwork, it's still in problem. Yeah. It's the same kind of story. But they are, kind of in the process of trying to alleviate that some. So that's a great question. We're always finding creative ways to kind of decompress our waiting rooms. Unfortunately, these patients that come through the ambulance, those are the main revenue generators. When we go in diversion at 11, 12 o'clock, we're really diverting a lot of revenue too, because we can't take any more.
So you mentioned that, especially in like recent years and recent months, your hospital stuff has been changing. Has been changing. What are some of the major changes that have been happening across the healthcare system in America?
Yeah,
Affect you as a doctor personally?
At MCV in particular?
Yeah, sure.
Yes.
I mean, nationwide, and local, state, how, you mentioned everything is changing. So
Sure, yeah. No, we are definitely going through a major change. Nationally, with this whole healthcare reform, I think you'll notice a big surge in terms of our ED volume. Patients are not going to the primary care doctors anymore. Because a lot of PCPs are like not accepting any Medicare or Medicaid patients. And that's the majority of the patients that then come to us. So that's a major healthcare issue that we're kind of trickling down to the ED. From a VCU standpoint, we're doing the VCC program. We're trying to change the landscape of our ED, so that's like, it's a big hike to kind of get everywhere. The footprint of VCU and our emergency department is huge right now. But we're expanding our beds from, I believe, like 60 to 100. So we're trying to make changes so that we can deal with this like surge that we're having in volume. But it's still very much a work in progress. But VCU is going to be a very exciting place to come, to work, to shadow, to think about doing medicine at in the coming years. Because, our emergency department, we're growing, we're getting a lot of cool attendings that are coming from out of the country, we're doing a lot of cutting edge research. And then, the healthcare issue, unfortunately, you just have to deal with. It definitely does put a cut in our salaries. There are attendings out there that said they were making like $500, and now they're, it's going down. Because everybody that comes to the ED is Medicare, Medicaid. So it definitely like trickles down in every aspect. So then you have a lot of ER doctors that are leaving emergency medicine and doing other things like opening up salons and doing radios. Because there's burnout is a big thing in emergency medicine. You can get burned out very easily. So it's very important to diversify, people that are working all the time in the ED. That's why I did my PhD, so I could do something else in addition. And then when you don't get compensated, a lot of ED physicians are leaving and doing other things.
VCU has been, I just want to interject this, it has been tremendous. How many of my mentorship students are at VCU or MCV?
Oh, wow.
Yeah.
I didn't realize that. Anybody in this? Oh, wow. Like the same hands go up. Okay. Well, let me know if y'all are interested in emergency medicine. I have my cards. If anybody wants to get in touch, my brother and I would love to have you.
I'm in emergency medicine. I did my membership with Dr. Wolven in the Peds.
Woolabin. Oh yeah, Chris Woolabin. Yeah. That's a lot of fun too. And we just opened a new Peds ED. So they always say when you build, they'll come. So we just opened a new pediatric emergency department. So a lot of little kids start coming to, and we've done a lot of good things there. We have 2 or 3 resuscitation rooms, and we are now the Children's Hospital of Richmond, so we get all the major trauma and major cases. We have every specialty except I think plastics, peds plastics at MCV. So I think EVA has that. Thank you all so much for having me. Great things. I was telling Mrs. Taylor and Mr. Waller, I said if I was applying now, the governor's school, I probably would have never gotten in. So really bright mind.